The spinal cord and meninges. Anatomy. In spinal flexion, the spinal canal is approximately 11 centimeters longer than it is in extension. This means that the contained neural tissues, such as the spinal cord and the meninges, will be physically challenged. In this position, if neck flexion was added, there would be even more challenge on these neural tissues. Therapist assessment, passive neck flexion. This is like a straight leg raise, but from the other end. There are two ways to consider doing it. Upper cervical flexion is a form of passive neck flexion. This will challenge the cranial and cervical meninges, and a full passive neck flexion involves upper cervical flexion and neck flexion. 25% of patients with low back problems will get symptoms on that test. Therapist assessment, the straight leg raise. Straight leg raise can also be used for the spinal canal contents. In straight leg raise, there will be movement of neural tissue right through the spinal canal. Just note the handling. One hand is above the patella and my right hand is above the malleoli. Straight leg raise for a more mobile person. For a more mobile person, you'll need to put their leg on your shoulder and then walk up towards them. Therapist assessment, straight leg raise and the sensitizing movements. In straight leg raise, more load can be placed upon the nervous system and thus aiding structural differentiation by hip adduction, hip medial rotation, and in addition to straight leg raise, hip adduction, medial rotation, neck flexion can be added. Further load can be placed upon the nervous system by performing the straight leg raise in the patient who already has their spinal canal laterally flexed. Lateral flexion means that the spinal canal on the convex side will be 15% longer. Structural differentiation in this position can be performed by adding neck flexion. Therapist assessment, the bilateral straight leg raise. The bilateral straight leg raise places different forces on the meninges than a single straight leg raise, and this may be appropriate in someone, for example, who's having trouble sitting or maybe a rower. Here are some techniques I might perform in this position. In bilateral straight leg raise, I'm performing a dorsiflexion technique. The technique can be progressed if I performed it in a little more hip flexion. And of course, this could be easily converted to a self-management exercise. Therapist assessment, slump test. The stages are spinal flexion, neck flexion, knee extension, and then neck extension to see if it alters evoked symptoms. Notice how the knee can often be extended further on neck extension. For closer handling, spinal flexion. Now neck flexion, guiding the flexion. One arm rests gently on the head. The knee extension is encouraged up to symptoms, and then very carefully the neck extension is taken off in stages. The smaller the amount of neck extension that eases evoked symptoms in the leg will give you a better manual therapy diagnosis. Therapist assessment, the slump test on a more flexible person. Notice how the subject sits well back on the bed. This is Rookie, one of our students. Spinal flexion, neck flexion, knee extension. There's no symptoms here, and I can take the hip into further flexion, even add hip adduction and medial rotation. Symptoms are evoked there now, and it can be structurally differentiated by neck extension. Notice how the leg can be extended a little further. Therapist assessment, the slump long sit. Note the stages: spinal flexion, note my knee supporting the pelvis, neck flexion, extension of the left knee, extension right knee, checking symptoms with each component. Dorsiflexion can be added if required, or if the person's too tight, put pillows under their knees. Structural differentiation is available via the neck. A more refined analysis for upper thoracic problems can be performed in the slump long sit position if the cervicothoracic area is stabilised and neck lateral flexion performed. Here's a close-up. I've got the C7-T1 area stabilised, and then I'm checking the effect of adding neck lateral flexion on this position. This will frequently evoke symptoms in the upper thorax. Structural differentiation can be performed by flexing the knee. This may be challenging thoracic meninges, maybe even thoracic sympathetic nervous system. Therapist assessment, structural differentiation. Rookie has a problem in her left leg. Notice how I can flex her spine, including neck flexion, quite a lot, as long as the left knee is in flexion. If I was to perform the same movement with the knee extended, she finds it almost impossible to flex her spine and neck. And with the knee flexed, spinal flexion is allowed. There is clearly a limitation in the nervous system's movement and its ability to stretch. Passive techniques in leg distraction did next slide a tensioner. If the leg is distracted, this provides a gentle elongation on the spinal canal. At the same time, if I ask Claire to extend her neck, a slider movement is allowed and a gentle, distracted movement along the whole spinal canal is allowed. If the same technique was performed in a little more straight leg raise, this would allow more movement to be placed upon the neuromeningeal tissues. Passive techniques. In slump long sit, did thoracic techniques. Claire is in the slump long sitting position with a pillow under her knees. I'm now laterally flexing her thorax, which opens up the spinal canal and challenges neural tissue on the convex side. Gross movements can be performed, or more localized techniques, such as this lateral mobilization of the spinous processes. The technique should feel comfortable. Here, I'm mobilizing a rib in the slump long sit position. This may be a way to mobilize the sympathetic trunk and ganglia lying underneath. Passive techniques in slump long sit, thoracic AP movements. This technique is useful for the flat thorax or even the lordotic upper thoracic spine. Notice here, one hand is on the sternum and my left hand is above the level to be mobilized. Both hands work, creating more spinal flexion in the slump long sit position. A little pillow on the sternum might be needed for comfort. The technique should feel comfortable. Most manual therapy pushes things in, but this is a pushing out. And the spinal canal in the thorax is as large as it can be. Passive techniques. The notalgia paresthetica technique. Sometimes the lateral branches of the posterior primary rami of the thoracic nerves get entrapped and may cause little spot pains, sometimes referred to as trigger point pains. In the slump long sit position, a massage technique can be performed on them, either generally for the more sensitive ones or more specific using one finger on the particular nerve. Sometimes a small nodule can be felt under the fingers. For the upper thoracic nerves, the shoulder blade will need to be protracted. Passive techniques, wedge mobilisation. These small wedges can be used. The spinous processes lie in the groove, and the lip of the wedge allows a very close, specific mobilisation of joint and neural tissue. Here I've placed the wedge on Claire's T5 level. Her spinous processes are lying in the groove of the wedge. My left arm supports her head. My fingers are on the lip of the wedge. I have a towel on her sternum, and via the ribs I'm mobilising the T5 level through the sternum. Quite a significant range of movement can be felt. However, if that same technique was performed in straight leg raise, there would be less movement, and even less movement in bilateral straight leg raise. This joint movement is a way of mobilising localised neural tissue dysfunction in this area. Passive techniques, wedge mobilisation techniques for the cervicothoracic junction. Here I've placed the wedge on or about Claire's T1, T2 level. Notice how her head is supported and my right hand rests on her clavicles. There's no force through the jaw, and the whole head and neck is retracted back. This allows a superior mobilisation at the cervicothoracic junction, and it can also be converted to more of a neural mobilisation if the same technique is performed with the arm in an upper limb 1 position as here, or of course you could put the arm in any neural load position that you wish. Self-management, some gentler techniques. Pelvic tilt with the neck slider tensioner. If the pelvis is tilted and the back flattened onto the bed, this provides spinal flexion, which is a gentle neural challenge, and if the neck is extended at the same time, this provides a slider movement. It's also a nice way to achieve pelvic movement in a distracted way. Here is the tensioner technique, and the patient, of course, can perform these techniques by themselves as part of self-management. Self-management gentler techniques, straight leg raise with a neck slider tensioner. We've used this technique a lot in the DVD, but it's also a technique which mobilises the entire neuromeningeal system. Here it is as a slider, and here it is as a tensioner. Self-management, stronger movements, the ring technique. Here I've asked Claire to do spinal rotation. This is a good joint and muscle mobilisation, but it also creates a ringing movement on the neuromeningeal tissues. If the head is taken the opposite way, that will be further neural mobilising, and then note Claire's also tucking her chin in as she rotates. It could be taken further. You could also depress the shoulder girdle as well. But imagine wringing the spinal cord and neural tissues as though you were wringing out a wet tea towel. Self-management, stronger technique, slump long sit with a shoulder shrug. Claire's leaning on the wall here. As she's extending out her left knee, I've also asked her to elevate her shoulder girdle. The elevation of the shoulder girdle releases some of the load on neural tissue, so it's a slider technique. And of course, it could also be done using the neck, but the shoulder girdle position may be useful for patients whose necks are too sore to use. Self-management, stronger techniques. We call this the kick your head off technique. Claire's holding her thigh, extending her knee, and extending her neck at the same time. I'm getting her to imagine she's kicking her head off. It's a slider. Here's the tensioner movement. Self-management, stronger movements. A slump tensioner focusing on the perineal nerve. The same technique can be performed here with the foot in plantar flexion inversion. And of course you could also do it with more of a focus on the tibial nerve if the foot was held in dorsiflexion eversion. Self-management, stronger techniques, wall walking. Claire is in supine and walking up the wall. Note that her hips are some distance from the wall. As a progression, if she moved closer to the wall, this would be more aggressive along the whole neural tissue system. Self-management, stronger techniques, the total slump. I've got Claire to squat, and then to tuck her head in first in spinal flexion, and then to stand up and flex her spine. Using order of movement principles, this is an aggressive mobilisation, focusing on neural tissue in the cervical spine. You may need a chair or a bed to balance. Self-management, stronger techniques, the rollover. This technique may not be for all patients, but as you can see, it provides an aggressive total neural mobilisation. In this position, Claire is now doing a little more straight leg raise.